Hi, this is Eve with True Crime and Coke. You are about to listen to an EDUsode. These are shorter episodes dedicated to educational information ranging from forensic terminology, crime facts, body processes, to interesting FBI files. But if you want to hear anything about true crime, disappearances, conspiracies, hauntings, and anything strange or unusual, then go to one of my regular episodes. Disclaimer: I am not associated in any way to the criminal or medical field. So in other words, I may not even know what I'm talking about. Now that that's out of the way, let's begin. Hi, and welcome to EDUsode 9, continuation of EDUsode 8, which was a continuation of EDUsode 7, all about drowning deaths. So no matter how long this takes, I will get through this, so we won't have several weeks of just drowning EDUsodes. So over the weekend, July 4th weekend, we had in Oklahoma a lot of drownings. So I bet if you look around your state around the 4th of July weekend, there were lots of drownings as well. These are usually due to intoxication, lack of parental supervision, no life jackets, and all of that. So before they do an autopsy on a drowning victim or supposed drowning victim, it is imperative, like I said before, that they do a proper investigation to document the surroundings, how they were found, all of that, because that will affect the autopsy and the results. I will warn you before I start talking about all the autopsy stuff that it is kind of boring, so just as a warning. Drowning is largely an asphyxial process with effects on multiple organ systems. The lungs, the anatomic center for respiration, are the primary organs affected by drowning. Respiration is an involuntary process under the control of the central nervous system in response to changes in blood and tissue oxygen and carbon dioxide, oxygen O2, carbon dioxide CO2 levels, and the blood pH. Diffusion and exchange of these gases occurs across the alveolar capillary membrane interface propelled by inhalation and exhalation. Oh, and I'm not going to break down exactly what everything means, or this will turn into like a 10-hour episode. Cartilage and innervated smooth muscle help maintain patency of the airways in order to allow unobstructed movement of O2 and CO2. Activation of the laryngeal nerves by potentially obstructing foreign objects or fluids trigger laryngospasm, a protective mechanism. Ciliated respiratory epithelium, mucus, and the cough reflex help to trap bacteria and other particulates and keep the airways clear and free of obstruction. At the alveolar level, patency is further maintained by the action of surfactant. Prolonged obstruction at any level can lead to low or absent oxygen or tissue oxygen levels, or hypoxia or anoxia, and low arterial blood oxygen levels, hypoxemia. This defines asphyxia. Ultimately, irreversible neuronal cell injury and cardiorespiratory arrest will result if the cause of the obstruction is not removed. Animal drowning experiments and case series reports of human drownings have augmented our understanding of the sequence of events and physiological effects. And yes, the animal drowning experiments suck big time, and it seems like we would rather have human drowning experiments over the animal drowning experiments, but I think we are just animal lovers, and hopefully in the non-bestiality way. Factors that precipitate drowning itself may be at play even before the actual drowning process begins and starts with contact with the watery environment. From the point of immersion of the body in which the face is not submerged to submersion of the face with obstruction of the upper airway, multi-organ system physiological effects happen. Immersion of a body, particularly at temperature extremes, has physiological effects and can lead to submersion and precipitate drowning. Immersion in hot water, particularly at temperatures greater than 38 degrees Celsius, such as in hot tub environments, has known physiological effects, particularly on the cardiovascular and thermoregulatory systems. These effects include ventricular arrhythmia, tachycardia, vasodilation, and hyperthermia, which may be deleterious in individuals with ischemic cardiomyopathy due to coronary atherosclerosis and hypertensive cardiovascular disease. The effects of cold water immersion include rapid cooling of the skin or cold shock, gasping, cardiac arrhythmias, skeletal muscle fatigue, and rapid loss of body temperature leading to hypothermia with loss of consciousness and multi-organ failure. Temperatures at or below approximately 25 degrees Celsius evoke many of these known physiological responses. Ultimately, the inability to extricate oneself from the cold water environment increases the likelihood of submersion with drowning. Other factors inherent in the body of water itself, such as swift-moving water, strong currents, underwater fixed and moving objects, and dangerous aquatic life are also precipitants of drowning. Immersion of more precisely the pre-submersion phase in which the individual maintains the face above water by treading will continue until the point of fatigue in deep watery environments. This is followed by a submersion phase in which the covering of the nose and mouth will trigger a series of physiological responses beginning with voluntary breath holding or apnea. The entire head need not be submerged, and thus drowning can occur in as little as a few inches of water that could exist in buckets, wash basins, and shallow natural bodies of water like streams. Breath holding continues until a certain break point or critical blood O2 concentration and CO2 is reached, causing states of hypoxia, hypoxemia, and hypercarbia. This break point triggers an involuntary gasping response, which would ideally lead to inhalation of air if head is above water. But by being submerged in the now hostile watery environment, water and any admixed debris enters the airway. There is inter-individual variability in the amount of water inhaled, and as little as 1 milliliter per kilogram up to 11 milliliters per kilogram of water can precipitate the drowning process. Swallowing of water may occur simultaneously, increasing the risk of vomiting with aspiration of gastric contents, which can occur as a result of stimulation of the innervated mucosa of the oropharynx and larynx by water. Whether this actually limits or precludes further entry of water into the lungs, leading to so-called dry drowning, remains unclear and unsubstantiated, prompting the World Congress on Drowning to abandon use of the term. Subsequent relaxation of the larynx will eventually permit water to be inhaled into the lungs. The worsening hypoxia and hypoxemia initiated by the impaired oxygen diffusion in the lungs leads to anoxia, depletion of brain energy reserves with deterioration of brain function, failure in brain energy metabolism, loss of consciousness, and irreversible neuronal cell injury. Irreversible neuronal cell injury may begin approximately 4 to 6 minutes after sustained oxygen deprivation, and the degree of partial or total recovery after a submersion event is dependent on the extent and regions of the brain affected and the promptness of resuscitative efforts. Aside from the neurological effects arising from pulmonary oxygen impairment, worsening hypoxia may also trigger an asphyxial or hypoxic cardiac arrest. Profound systemic hypoxia coupled with hypercarbia also leads to respiratory and metabolic acidosis, cardiovascular collapse with multisystem organ failure, and eventually death. The presence of fluid, commonly water, within the terminal airways and alveoli disrupts the free diffusion of O2 across the alveolar capillary interface. Compounding this process is the dilutional and or disruptive effect of even small amounts of inhaled water on surfactant. Surfactant, a lipoprotein secreted by type 2 pneumocytes, coats the alveolar surface where it acts to reduce surface tension, allowing the alveoli to remain open and available for O2 diffusion. With submersion and inhalation, the relatively Hypotonic fresh water will also diffuse across the semi-permeable alveolar capillary membrane into the pulmonary microcirculation and be circulated throughout the body, causing dilution of electrolytes of historically debatable clinical significance. The hypertonicity of seawater draws plasma out of circulation into the alveoli, causing some degree of hemoconcentration. The semi-permeable alveolar capillary membrane also allows for transudation of blood proteins into alveolar spaces, causing pulmonary edema. The influx of alveolar fluid results in dilution or alteration of surfactant, whether caused by fresh water or salt water, leading to collapse of alveoli and rendering them unavailable for O2 diffusion into the capillaries and diffusion of CO2 from the capillaries. As a result, venous blood is shunted past unventilated areas of the lung, altering the ventilation to perfusion ratio and increasing pulmonary vascular resistance, leading to systemic hypoxia and acute respiratory distress syndrome, or abbreviated ARDS. If submersion is prolonged, exceeding 4 to 6 minutes without prompt resuscitation, irreversible neuronal cell injury along with the development of hypoxic ischemic encephalopathy clinically ultimately results in cardiorespiratory arrest and death. The shorter the time frame from submersion to resuscitation, the more complete the recovery. Limited neurological sequelae and more complete recovery have been reported, especially in children or those with uncomplicated environmental or clinical hypothermia. Potentially lethal complications following drowning include acidosis, multi-organ failure, rhabdomyolysis, ischemic kidney injury, and coagulopathy. Even with prompt resuscitation, the effects of aspirated water and other fluids can persist, and other complications can arise within the interval of an in-hospital survival and following discharge. Post-immersion syndrome or secondary drowning have been used to describe both short-term and long-term pulmonary effects of water or fluid inhalation. Inhalation of chlorinated water from pools or cleaning products can cause a chemical pneumonitis. Swallowing and distension of the stomach can precipitate vomiting with aspiration of acidic gastric contents, causing chemical pneumonitis, or lead to aspiration pneumonia with subsequent respiratory failure and death with or without sepsis. Pneumonia, sinusitis, and central nervous system infection may develop more than a month following the drowning event as a result of inhalation of waterborne bacteria, amoebas, and fungi. Clinical and pathological sequelae of drowning with inhalation of unusual fluids, such as oils and syrup, have been reported with features of asphyxia and distinctive findings relative to the drowning media. Near drowning has been used in certification of deaths occurring within 24 hours of following submersion and encompasses complications arising from drowning asphyxia. Okay, so that was the process and pathophysiology of drowning. Now we will move to why it is important to have a historical context for pre-autopsy processing. Ordinarily, routine and recreational water-related activities, whether indoors or out, pose little bodily threat. Alteration of human and/or environmental factors, however, may turn a docile watery environment into a hostile one and lead to drowning. The late and renowned Dr. Joseph H. Davis referred to this as the drowning equation, in which drowning is the constant and the end result, and human and environmental factors represent the variables. From this equation are derived specific questions of investigative importance. Was the victim alive or dead before entry into the water? Did the victim drown? Why or how did the victim get into the water in the first place? Why was the victim unable to survive the water? Addressing each question by way of a thorough investigation and autopsy performance with toxicological analysis will aid in answering them and properly certifying the death. Questions will arise regarding recovery of a nude body, prompting a search for the explanation, such as stripping off of clothing caused by rough water conditions or snagging against underwater debris versus a dumped body with death by other means. Questions may arise relative to specific locations or water conditions. Is a body found on the seashore representative of a drowning death left exposed by receding tides, transportation from another location, or a collapse and death from some other reason while near water? Is a body found in a bathtub representative of death due to natural disease with terminal collapse, A homicidal drowning, or a drowning coupled with some precipitating factor such as drug or alcohol intoxication. Is the palpable or measured body temperature assessed on scene consistent with the water conditions, particularly cold water conditions, and are there signs of hypothermia? Drowning can take place in as little as a few inches in water, such as ditches, puddles, wash basins, hot tubs, and buckets, which would ordinarily be escapable, and thus identifying factors such as intoxication, catastrophic natural disease, injury, disability, young age, or underdevelopment is necessary for explanatory purposes. The condition and intactness of the body will prompt questions regarding time of death, postmortem submersion interval, PMSI, and identification where application of knowledge of taphonomic factors associated with different types of natural watery environments will be necessary. Now I am going to give you some water-related deaths with corresponding examples. One is a natural death preceding or during submersion. Coronary artery thrombosis with sudden cardiac death while swimming, fatal arrhythmia due to cardiac channelopathy while underwater swimming, and non-traumatic seizure disorder with seizure onset while swimming can make a natural death look like a drowning. Example 2, homicidal drowning. Forcibly holding or pulling victim underwater, pushing a victim into water, victim incapacitation by inflicted injury or intoxication while in or near water. Example 3, homicidal injury with body disposal, lethal, blunt, sharp, or asphyxial injury followed by weighted body submersion. Example 4, suicidal drowning. Submersion assisted by self-tying of hands and or feet, use of weighted materials such as a backpack filled with large rocks. Example 5, accidental drowning, precipitated by swim fatigue, swim inability, drug and alcohol intoxication, equipment failure, carbon monoxide poisoning from a motorized vessel, incapacitating injury, rough, swift waters, temperature extremes such as hypothermia, entanglement by underwater objects, unsecured or unsupervised locations such as ponds, lakes, or pools, electrical current from defective pool lights, electric current from appliance submerged in bathtub, entrapment by pool drains. Example 6, an accidental death from trauma preceding or accompanying submersion with drowning. Lethal blunt force, head, neck, and torso trauma from fall, diving with impact, or watercraft collision. Example 7, non-traumatic accidental death precluding the drowning process. There might be pre- or peri-submersion lethal drug or medication overdose. Pre-autopsy information of investigative importance is necessary for interpretive context in water-related deaths and may be sparse or non-existent altogether, and all efforts to obtain any available information is necessary. These include decedent identification, location of body, condition of the recovered body, type and extent of recovery efforts, the type and extent of resuscitative efforts, if any, and the presence or absence of any personal effects and life preservers. Witness accounts of the decedent's appearance and state of dress, state of mind, activities prior to submersion, and signs of impairment prior to entry into a body of water can provide explanation as to how and why the submersion happened. Establishing the identity of a victim can lead to information regarding medical history, psychiatric history, and substance use history and give direction and focus to the investigation and autopsy. The medical legal death investigator, or MDI, performs the requisite functions, becomes instrumental in obtaining relevant death scene information through scene visitation and direct observation or from other first responders, and provides written and photographic documentation along with a report to be reviewed by the forensic pathologist. As representatives of the medical examiner's or coroner's office, MDI also serves as an initial point of contact for law enforcement and technical recovery personnel and the conduit of information between these personnel and the forensic pathologist. Generally, the investigator will document bodily findings relative to immersion or submersion and drowning, in addition to environmental and water conditions, whether in a natural setting or indoors. The position of the body is found prior to arrival becomes vitally important in determining if the victim was submerged at all, and if so, to what degree, as in the case of bystander resuscitation in which the body has been moved or repositioned. Noting the presence, condition, and state of dryness or wetness of the body and any attached or detached clothing is important for any scene. Certain scenes will require focus on documenting or uncovering additional pertinent findings. Signs of bathing, such as wet towels, drain position, the proximity of electrical devices, the presence of a soap scum level, or signs that the body was moved, are some important factors for bathtub drownings. The presence of a lifeguard, video surveillance, witness observations, evidence of access through an unsecured gate, and swimmability are a few pertinent factors in pool drownings. In drownings occurring in natural environments, underwater and land topography, water temperature and conditions, the lack of safety gear, signs of intoxication, state and type of dress, and signs of bodily trauma are important to note. Other important information includes any medical and psychosocial history or history of trauma. Suspicious, homicidal, and equivocal death circumstances or unusual bodily findings may warrant consultation with and scene visitation by the forensic pathologist. Obtaining and reviewing reports that document information including scene attributes, evidence recovery, body recovery efforts, weather and water conditions, indoor scenes, and resuscitative efforts may be helpful for the forensic pathologist to interpret autopsy findings and properly certify the death. These reports include police reports, technical dive team reports, Coast Guard reports, emergency medical service reports, and the report prepared by the MDI. Review of any ancillary reports relative to examination of safety gear, underwater breathing gear, watercraft, or implanted medical devices such as pacemakers may be helpful prior to any final cause and manner of death conclusion. In drownings that involve an in-hospital survival interval, medical records documenting clinical pathological sequelae can be helpful since the classical findings of acute drowning may be absent at autopsy. Due to ongoing investigation, many of these reports may not be completed at the time of autopsy, which will require verbal and/or electronic communication with the relevant investigator. These communications, inclusive of contact name, date, and summary of information relayed or received, must be documented in the case file. Depending on the known death circumstances and body condition, the initial pre-autopsy processing of a body may be necessary. This involves the collection, preservation, and examination of on-body evidence, such as clothing, items found in clothing, including articles of identification, body wrappings or binding materials, and sampling from body regions for foreign materials. The identification of binding materials or items used as weights and the precise way in which they are affixed to the body is of particular importance and can have bearing on manner of death determination, especially suicide versus homicide. Notation of the type, condition, and wetness of clothing and any adhered aquatic debris is important as it may correspond to victim's appearance when last seen or characteristics of the location where recovered. Biological material may contain DNA, and while recovery of DNA from submerged biological fluids such as saliva, blood, and semen has been demonstrated, the success of recovery of undegraded DNA is greatly and sometimes rapidly reduced in the setting of prolonged submersion and decomposition. Successful identification using DNA of dismembered and disarticulated remains submerged for extended times have been reported. Other more traditional scientific means of identification, such as fingerprinting, radiographic documentation of surgically implanted devices, or unique skeletal attributes such as craniofacial sinuses and odontological comparisons, may be necessary. Fingerprint enhancement techniques have been used in the identification of submerged remains. Unique body features like piercings and tattoos and other on-body items such as engraved jewelry or dentures can provide presumptive or confirmatory identification. Any on-body diving and personnel safety equipment should be retained for later examination by respective experts for examination of condition and functionality. If feasible, a submerged vehicle containing a body or bodies should be transported in its entirety to the MEC in office for in situ examination of the body or bodies and vehicle, which may provide clues regarding circumstances leading up to the vehicle becoming submerged. Pre-autopsy radiographic images can be helpful in locating projectiles, other retained foreign materials, and the identification of air within body cavities and incidents involving underwater breathing gear. And now we are finally to autopsy. In forensic pathology practice, the diagnosis of drowning as a cause of death follows exclusion of other causes and requires the performance of a full autopsy with testing of bodily fluids and interpretation of all results in the context of all known historical and investigative information. In the absence of multiple supportive findings of drowning, consideration of another non-natural cause of death is warranted. As stated previously and for emphasis, bodies recovered near or within a body of water can represent a death from a variety of different causes and manners other than accidental drowning. While autopsy performance affords external and internal access to much of the anatomy to assess for findings of drowning, post-mortem whole-body computed tomography, or WBCT, has been shown to be increasingly useful in the non-invasive documentation of these findings. Excessive fluid and sedimentous material in the sinuses and cavities of the head and chest, oropharynx, lungs, stomach, and small intestine have been identified in drownings. Identification of density differences as a result of hemodilution or hemoconcentration in viscera have been used in the differentiation of fresh versus saltwater drownings. External findings in drowning deaths vary and are both nonspecific and non-diagnostic. Some findings are merely indicative of a period submersion in which there has been contact with water of sufficient time to cause visible changes. The PMSI characteristics such as water temperature and current, time elapsed between recovery and autopsy, medical interventions, and any in-hospital survival time are all factors affecting what may or may not be visible. The more prolonged the PMSI, the less prominent or potentially more confounding will be the findings by the time an autopsy is performed. Injuries of various types, number, and distribution may be found. Blunt force injuries, such as abrasions, contusions, and lacerations, are most common. These may have been sustained on land prior to submersion, on impact with water or objects in or near water, or while submerged. In larger bodies of water, the manner of injury, the presence of moving or fixed natural or man-made objects, water current and wave action, underwater topography, and predation by marine or terrestrial carnivorous animals will play a role. Resuscitative and recovery efforts may cause abrasions and contusions of the chest, face, neck, or the inner and proximal aspects of the upper extremities, and sparse facial or scleral petechiae may be present. The presence of injury may depend on factors that impede or protect the body from being impacted and include those that affect body buoyancy. These factors include adiposity or fat, the presence of buoyant clothing or flotation devices such as life vests, and the amount of air contained in lungs and intestines, and will determine the depth to which the body will sink, along with the potential to sustain injury from contact with objects. Clothing and wetsuits may protect the skin from injury. In deeper waters, the body often assumes a prone position with the head down and the extremities dangling downwards, known as the drowner's pose, as it sinks to the bottom. Post-mortem travel abrasions and lacerations on exposed body surfaces, such as the forehead, backs of the hands, knees, and tops of the feet, can appear as the body is dragged against the bottom surface or propelled by a wave. Injuries may be antemortem, with gross or microscopic evidence of vital reaction, such as hemorrhage and inflammation infiltrates, or postmortem, with lack thereof. Questionable injuries should be examined microscopically. Whether sustained in the antemortem or postmortem setting, animal predation can cause superficial or deep disruption to organs, soft tissue, and bone, and leave patterns characteristic of the type of animal. Postmortem predation by marine or freshwater fauna and environmental taphonomic changes can also alter, confound, or obscure antemortem injury and include dismemberment, disarticulation, tissue loss, and skeletonization. Identification of chop-like cutaneous wounds with characteristic periodicity will be helpful in reconstruction of injuries caused by boat propellers. Leaching of blood out through open wounds and decompositional changes may make differentiation between antemortem versus postmortem injury difficult or impossible. Where bare skin is exposed to air, a parched, darkened, leathery appearance can result in obscure superficial injury. Physical injury may be lacking altogether in certain cases of drowning, such as those involving electrocution. Thermal and chemical injuries subsequent to immersion or submersion with drowning in liquid mediums such as gasolines, hot oils, and waxes have been reported. Other injuries that are not related to drowning may give clues to the circumstances that may have precipitated drowning, such as the presence of track marks indicating intravenous drug use, healed incised wounds of the wrists indicating previous suicide attempts, or surgical scars indicative of disability. In bodies without significant decomposition or prolonged resuscitation, the typical findings associated with drowning are more easily identified. Exudation of a column of white or pink froth from the nostrils and or mouth is often apparent or becomes apparent by simply pressing down on the chest. It is a manifestation of the mechanistic action of terminal respiratory efforts on an admixture of residual intrapulmonary air with intrapulmonary drowning and edema fluid. The froth or foam cone is seen in other types of deaths with increased pulmonary edema, such as drug overdoses and congestive heart failure of various causes. Depending on the time elapsed since recovery, the skin and hair may be wet, damp, or dry. Pallor with wrinkling of palms, soles, fingers, and toes, sometimes referred to as washerwoman's hands or washerwoman's changes, may be noted. These changes are a result of dermal absorption of water appearing in fingertips in as little as 20 to 30 minutes after immersion or submersion and disappearing slowly upon exposure to open air and thus may be unapparent at autopsy. So, okay, if you've been like in the bathtub too long or in the shower too long and, your hands and stuff start looking weird and wrinkly, that's what they're talking about. If recovered from natural water environments, adherent aquatic debris such as silt, mud, sand, gravel, vegetation, algae, and shell fragments may be adhered to the skin surface or found in body creases, cavities, or orifices such as the gluteal folds or butt crack, nostrils and mouth, or found in the scalp hair. Rigor mortis will be apparent depending on water temperature and duration of submersion, except in decomposed bodies. Rigor mortis affects all skeletal muscles, including the erector pili muscles and skin, causing cutis anserine, or so-called goose flesh, and can be seen on submerged and non-submerged skin alike, and is not specific only for cold water immersion. Lividity will be most apparent in the face, neck, chest, hands, and lower extremities and feet in a prone body, but may be unapparent or incompletely formed in bodies subject to fast-flowing water. The color of lividity should also be noted, as it may be informative in direct specific postmortem testing. For example, bright red or pink lividity may be observed in cases of drowning precipitated by carbon monoxide poisoning from inhalation of boat exhaust fumes or deaths associated with hypothermia. Cyanotic congestion may be seen in the face and neck and indicates a state of terminal hypoxia. Scuba-related drowning deaths, or those with impacts causing rib fractures and lung injury, may exhibit palpable crepitance signifying subcutaneous emphysema. The many alterations conferred by postmortem decomposition add another layer of difficulty in regard to the determination of the cause of death, time of death, and location of death in any death, and especially in bodies recovered from water. Recognition of the environment and its inherent features is necessary for context in the interpretation of autopsy findings and serves as a caution against overinterpretation or misidentification of findings. Decompositional changes look similar to those occurring on land and include skin discoloration, skin sloughing, marbling, production of purge fluids, and bloating, as well as corresponding visceral and soft tissue changes. These changes occur in part as a result of the body's autolytic and putrefactive processes, with additional changes conferred by colonizing organisms, and will be accelerated in warmer water and slowed in cold water. Bloating of an untethered body will inevitably cause the sunken body to float to the surface, maintaining a prone position, allowing exposed body regions to dry out, darken, and mummify or otherwise be exposed to predation, mold, and algal colonization. Even a body tethered with attached weights can float to the surface with the weights in tow. Occasionally, the floating decomposed body may present with the anterior side up, allowing the face, chest, and abdomen to be exposed to artifacts of drying, predation, and larval colonization. Changes of decomposition generally occur more slowly in water than on land and are affected by factors inherent in the water, such as salinity, temperature, especially cooler temperatures, marine life, bacterial composition, currents, absence of flies and fly larvae, and contact with underwater objects. Saltwater presents a slower rate of decomposition than freshwater due to retardation of bacterial proliferation as a result of the higher salinity. Bodies found in deep, cool waters owing to entrapment or are otherwise protected from marine predation may have little in the way of decomposition. The body may be nearly or completely defleshed to the point of skeletonization, aided by warm temperatures and or aquatic organisms, which may require the expertise of the forensic anthropologist to assist with identification and assessment of taphonomic changes. Bodies in damp or wet environments for prolonged periods of months or years may develop a chunky gray-white substance known as adipocere as a result of bacteria-mediated hydrolysis of body fat. While the time frame of development of adipocere varies depending on factors inherent in different watery environments, its preservative qualities are recognized, including the preservation of anatomy, skeletal injury, and toxicological evidence. In addition to adipocere, colonization by algae, larvae, and bacteria as part of decomposition may be apparent and have been used in the estimation of the PMSI, time of death, and location of death, sometimes requiring expertise in entomology and botany. Determinations made by the forensic entomologist or botanist can be of great investigative importance in the reconstruction of the circumstances leading to the death and identification of the decedent. In cases of prolonged submersion, decomposition will proceed rapidly following recovery, and these changes can obscure other pre-existing antemortem or postmortem findings. Therefore, prompt refrigeration followed closely by autopsy performance is necessary. Internal findings. It must be emphasized that there is no one finding that is specific for drowning, and all findings commonly associated with drowning must be interpreted within the context of the history and death circumstances. Many findings become less apparent or absent in the setting of significant decomposition, prolonged resuscitative efforts, and an in-hospital interval of survival. Classically, on an in situ examination, the lungs will appear voluminous, boggy, and crepitant with apposition or overlapping of the medial edges. Transudate fluid in the form pleural fusions may be present. The lung weights typically will be increased with combined weights in excess of 1 kilogram, without significant differences observed between fresh and saltwater cases. With increased postmortem submersion intervals, inclusive of decompositional changes, increased lung weights along with increased amounts of pleural fluid have been described. As a result of overexpansion with rupture of alveolar capillaries, blotching areas of hemorrhage, also referred to as Paltoff's spots, may be visible on the pleural surface. Extravasated blood resulting from alveolar capillary rupture is the likely source of the pink or red tinged froth noted on examination. Typically, copious white, pink, or red froth and fluid exude from the lumen of the sectioned larynx, trachea, and bronchial tubes, as well as the cut surfaces of the lung parenchyma. The fluid also may be admixed with aquatic debris. On histological examination of the lungs, intraalveolar hemorrhagic edema fluid in a patchy or confluent distribution is found, and an emphysematous-like alveolar pattern can be seen. Polymorphous aquatic debris such as sand, silt, shell fragments, diatoms, and fragments of aquatic vegetation may also be found. Though not scientifically reliable or commonly performed, extractions from lung tissue have been analyzed for the presence of diatoms to assist in the diagnosis of drowning or identification of drowning location with some limitation owing to the widespread domestic, industrial, and environmental distribution and their presence in tissues and organs in persons who have not drowned. In near drownings within in-hospital survival interval, pink hyaline alveolar membranes representative of ARDS or bronchopneumonia may be noted. Marked dilation of the right ventricle may be observed. Watery fluid admixed with aquatic debris may be found in the stomach as a result of ingestion during or after the drowning process. In cold water drownings, signs of vital reaction associated with hypothermia may be present, including punctuate green, black gastric erosions, also known as Winchowski's ulcers. Histologically, corresponding mucosal necrosis with hemorrhage and neutrophilic reaction may be seen. Cerebral edema may or may not be present, and with prolonged cardiopulmonary arrest followed by resuscitation with an interval of hospital survival, there may be histological evidence of neuronal eosinophilia as a manifestation of anoxic ischemic encephalopathy. Upon brain removal, the petrous ridges may appear dark red as a result of subcortical congestion with hemorrhage, purportedly as a result of pressure changes in middle ear pressure incurred by a sinking body. 5 to 10 milliliters of red-tinged watery fluid, sometimes admixed with aquatic debris, can be at times aspirated from the sphenoid sinus and also has been used in quantitative analysis of diatoms to support the diagnosis of drowning. Though again, this is not commonly performed as water could also enter this area after death. The finding of hemolytic intimal staining of the aorta in freshwater drownings is described, and an added supported finding knowing that this finding is also seen in other types of deaths and is a common finding in decomposed bodies. Multifocal hemorrhage may be seen in the skeletal muscles of the head, neck, and torso, in addition to the sclera, which, in the absence of other evidence of impact or strangulation injury, has been attributed to hypercontraction during struggling in the initial stages of drowning and elevated venous pressure. In acute drowning deaths, the remainder of the viscera and soft tissues will exhibit varying degrees of congestion. Injuries of various types resulting from impact with the water surface, bottom surface, fixed or moving objects, predation, or as a result of watercraft and boat collisions may be found and are important to document. Resuscitative injuries are often recognizable by virtue of their location and pattern, such as sternal fracture, anterior rib fractures, and tongue and pharyngeal tissue contusions. Tongue contusions and lacerations may also be supportive findings of terminal seizure activity. Determination as to whether the injury or injuries have lethal potential or are contributory as a result of their incapacitating effects is necessary. Similarly, the identification of natural disease entities with obvious lethality, such as aortic dissection with hemoperitoneum, or lethal potential, such as severe coronary atherosclerosis, sufficient enough to preclude the drowning process, along with absence of supportive findings, has obvious cause and manner of death implications. Special procedures. Death circumstances or autopsy findings that indicate the possibility of internal injury should prompt application of special dissection techniques. Cases in which barotrauma associated with deep diving deaths are suspected, such as identifying subcutaneous emphysema or thoracic cavity hypodensity seen on pre-autopsy imaging, warrant examination for gas embolism. This includes subcutaneous dissection of the outer chest wall for the identification of pneumothorax and or in situ puncture through the right ventricle in the evaluation for intraventricular air. Through again, these procedures can be difficult to perform and interpret. In deaths following diving into shallow water with potential head impact on fixed underwater structures, dissection of the anterior and posterior neck, possibly including in situ examination and removal of the spinal cord, is necessary to look for cervical spine injury, including vertebral fracture or fractures, especially at C5 to C7, dural-based hemorrhage and spinal cord contusion. Anterior neck dissection should be prompted by the finding of facial petechiae and cutaneous neck injuries in order to document any injuries of the cervical strap muscles, laryngeotracheal skeleton, or hyoid bone that indicate anterolateral neck compression caused by ligature of manual strangulation. Dissection of the sinoatrial and atrioventricular nodal tissues should be performed at least for retention and otherwise for histological examination, especially in an unexplained drowning such as that involving an experienced swimmer or an autopsy lacking findings of lethality. Retention with archival storage of heart muscle and whole blood samples are necessary in drowning deaths that are unexplained, have a decedent or family history of syncope or arrhythmia, or a family history of sudden unexplained death, in anticipation of submersion for genetic analysis for cardiac channelopathies as mutations have been identified. Forensic limnology is the science that examines the presence of diatoms in crime scene, suspect, and victim samples with application in the resolution of crimes. Continued focus via experimental study and casework application has been on the utility of diatom examination in the diagnosis of drowning. Researchers are careful to remind investigators of the importance of interpretive context of results and recognition of limitations, including low abundance in certain natural bodies of water, given rise to low and negative tissue levels, positive findings in individuals who have not drowned or have not been submerged, positive findings in individuals that have not drowned but have been submerged for prolonged periods, and methodological limitations of extraction from samples. Diatoms are also known for their nature being found in natural bodies of water, soils, and even tree bark, and can also enter lung tissue passively during prolonged submersion. Furthermore, certain diatom species are unique to freshwater and saltwater environments, with concentrations affected by conditions inherent in the water, which could have a direct bearing on interpretation regarding drowning location. Contamination leading to false positives for the presence of diatoms that could lead to a misdiagnosis also remains one of the issues of concern cited by researchers. With the development of more streamlined extraction methods with shorter turnaround times and overall higher sensitivity, and specifically the successful recovery of diatoms from a variety of tissues and fluids such as the lung, liver, kidney, bone marrow, and cavity fluid, along with comparison to that found in the drowning medium, has been shown to be an occasionally useful adjunct to not only the diagnosis of drowning, but also in the ruling out of drowning as the cause of death. That being said, due to the various difficulties discussed, diatom examination is not considered standard of practice when investigating potential water-related deaths. And what is a diatom, which I should have mentioned a long time ago? A diatom is a single-celled algae which has a cell wall of silica. Many kinds are planktonic, and extensive fossil deposits have been found. A very common use for diatoms is for filtration. The fine structures of diatom shells trap foreign particles in fluids such as dirt, lint, hair, and some other microscopic organisms. Diatoms are often used to filter water, particularly water in hot tubs and swimming pools. So basically, this sums it up. You can't always assume that a victim you find in water drowned. There could be several other reasons which you have to investigate. Other things we have learned, hopefully, from this long EDUsode is that it's not smart to mix swimming and drinking and doing drugs together. It's also not smart to not wear life jackets, even though you might be a great swimmer, because there could be things in the water that are holding you down. When I was a kid, I almost drowned because my foot was caught in, I don't know what it was caught in, but it was caught in something, and I was waving my arms for my mom to help me, but I couldn't scream or anything because I was drowning. But she thought I was waving, and she was just waving back hi, and her friend thought I was drowning and came and saved me. So just because you're a good swimmer, there's so many variables in the water that can cause you to drown. Also, muscle fatigue. You can truly drown from muscle fatigue. If you're swimming too long and against the tide and you're trying to get back to shore, your muscles can be so tired that they literally just give up and drown. Another thing to remember is also if you go swimming in like a pond, or heck, you even hear about it in swimming pools that are supposed to be clean and sanitary, is when they get that amoeba and they end up dying. Also, don't dive into shallow water. You will break your neck and die or become paralyzed. Also, it's not safe to be scuba diving and be like very deep down into the water, and then if you go back up to the surface too quickly, that is also very dangerous. So that's why there are a lot of novice scuba divers who die from not being trained well enough. And also you have to question the ones that are extremely experienced that die and they happen to be with a spouse when that happens. You really have to look into that too, because they do have extensive training on all kinds of scenarios. So a good thing would be to look and see if a life insurance policy was taken out shortly before the scuba diving death. And there are several cases of that in the past. Let's see. Also, bodies always end up floating to the surface. That's why you hear about some mob people or other people just know to eviscerate the victim's body organs and replace them with rocks. So that would help prevent gases from building up and floating to the surface. And also always supervise your kids, even if it is only a little bucket of water. There are many instances of them drowning. So this will end the EDUsode on drowning. Sorry it was so long, and there is still a lot more to it, but I have become bored with the drowning EDUsodes, and I believe my next EDUsode will probably end up being several because I want to do Samuel Little. So until then, have a good evening.